I'm hoping to spend as little time talking to you as I possibly can, not because I don't like the sound of my voice, but because I think that you'll be much better informed by hearing from the members of our panel than you will be by me. So I want to introduce the members of the panel, and after I introduce them briefly, I want to tell you on the sort of large scale what we're going to try and focus on, but we'll get into a lot more specific and concrete questions than what I've laid out on the large scale. And each of the panelists will talk for just a moment or two about what they do. But we have on the panel with us Dr. Nucci-Sack, who is the medical director of Mount Sinai Adolescent Health Center. We have Michael Johnson, who is the youth protection director for the Boy Scouts of America. We have Shawn Dre, who is a senior research fellow, Justice and Violence Prevention Program, the Institute for Security Studies in South Africa. And Carlos, I didn't ask you how to pronounce your last name, so I apologize beforehand. Carlos Lejniak?
Lejniak, yeah.
Lejniak, who is the CEO of Big Brother, Big Sisters of Essex in Newark, New Jersey. So before I have each of our panelists take a minute or two to tell you more specifically about what they do, and then get into questions of them, let me just say that our general focus for this panel is we're talking about organizations that help and serve youth, and with the idea, or these sort of background questions, big picture questions in mind. How does your organization address violence against children? What kind of support do you need to adequately serve these youth? And how do organizations support each other? And how can they improve in the way that they support each other? So, having laid that out, let me sit down and ask each of our panelists to begin by just saying a few words about what you do. Carlos?
Sure. So I'm the last-minute fill-in for a colleague who is a national expert on child safety. So I do apologize. She's the victim of the snow and the ripple effect of the snow from the Midwest. So I'm the head of Big Brothers Big Sisters in New Jersey, Newark, New Jersey. I've been there for about a decade. We had 100 kids when we started, have grown tenfold. And the formula is simple and impactful. One-to-one mentoring. We pair up a child with a one-to-one mentor through a structured program, get to know the child as they come in through the doors, and pair them up with an appropriate positive adult and structure a program that meets the child where they are and meets the adult where they are. And based in an urban center, Newark, Jersey City, we see a lot of the traumas manifest themselves, and we know, especially I heard yesterday there was conversation around the ACEs study and Kaiser Permanente's leadership and CDC's leadership on these things. If we don't get on the front end of our children's lives when they face those crossroads, it may manifest itself in the back end. Years later, decades later, and at that end, we're all paying for it. So we know the power of prevention, and we try to do this through a structured program called Big Brothers Big Sisters, a one-to-one mentoring model.
Thank you. Shawn Dre?
Good afternoon, everybody. So I represent the Institute for Security Studies, which is a policy think tank in South Africa, and a lot of my work is around developing policies to prevent violence against children and advocating for that. But I also work and have been working for the last 10 years with a community-based organization in a small community in a peri-urban area that is affected by many forms of violence. And it was started 10 years ago because young men became involved in violent gang fights over the weekends. And this is a community where more than half of the people are unemployed. There are high levels of domestic violence. Nearly 1 in every 3 women who's in a relationship is in a somewhat violent relationship, a lot of conflict at home anyway. A lot of social problems associated with intergenerational poverty and deprivation. And the first thing we did was start providing children with a safe place to go after school, hoping to get to understand their problems better and to encourage them to be more attached to school and to invest more in their own education. We've grown over the last 10 years from serving 9 children to serving 80% of the children who live in the community. Over 400 children in this small area come to our homework classes every month. And we had some early successes. Within the short time, some of the children from this community that never had one graduate before started attending university. Now, they've come back to our community, and one of them is chair of our board and is a teacher in the local school. But one of the things we learned was that the children who went on to university and did well were the children who were coming from homes that were loving and caring and supportive, but the children who were going home to homes where there was a lot of conflict and a lot of dysfunction were not able to succeed in that way at all. So 3 years ago, with the support of the University of Cape Town and the World Childhood Foundation, we started offering 4 parenting programs. One which is an infant attachment home visiting program, one which is a cognitive stimulation, a book sharing program for toddlers, and then positive parenting programs for kids and teens and their parents. And I'm very excited to be able to say that in this, we have the results of our second wave of a community survey, and we can show that over the last 18 months of delivering positive parenting programs, we've brought about a community-wide shift in the use of corporal punishment. And parents are monitoring and supervising their children better. And parents are starting to speak to each other about parenting and to share their new skills. So this is very exciting, and it tells us that something can be done and behavior can change, even in difficult circumstances. And that just leads me very briefly onto the work that I do as part of the Institute for Security Studies, which is about bringing together government, NGOs, and academics to figure out how do we take these kind of programs that we know work on a small scale and we might have shown to work on a small scale, and how do we make them available in communities all over the country where they're needed? It's a complex project, a very, very difficult undertaking that I think many countries are struggling with at the moment. And so what we've been doing over 3 years is really building the kinds of relationships that we need across these sectors in order for us to be able to challenge a really sticky problem like that.
Wow. Hi, everybody. My name is Michael Johnson. I'm Director of Youth Protection of the Boy Scouts of America. Before I get started, I want to share a quick little story to kind of get you in the perspective of what youth servant organizations do. You may see speakers sometimes ask the question of an audience, who is that person in your life that made a difference? And you would be very blessed if you could say it was your mother or your father. For a lot of children, it's not their mother or their father. And obviously, we've heard a lot about that these last couple of days. It may be a big brother or big sister. It may be a scoutmaster. It may be a teacher. It may be a coach. It may be a cub master, a scoutmaster, what have you. The point of the matter is, organizations that serve youth, and I've got a laundry list of them as I've been sitting here listening to all these incredible presentations. I don't know about y'all, but my head is like this. About all the things that we do and the impacts and the opportunities that we have and that we can make to assist with the American family and some of the challenges that youth are facing. Boy Scouts of America is a 107-year-old organization. We are primarily a camping, outdoor, values-based character and leadership development organization. We have 270 councils. Councils are programs that facilitate scouting programs across the United States and several countries. We have Cub Scouts, Boy Scouts, STEM, which is science, technology, engineering, and math, venturing programs, High Adventure, which is a co-ed program, Sea Scouts, and Exploring. We currently serve 2.4 million youth. We have almost 1 million volunteers spread out across those councils. And I'm proud to say in 2017, we had 55,494 Eagle Scouts. I'm even more proud to say that very near future, girls, young women will have the opportunity to become Eagle Scouts also. We think that's a big deal. Thank you very much. I'll let our chief know about that. He's pretty excited about the program, and we all are. We will always be, well, there is a responsible discussion about what we can do to prevent child sexual abuse. Well, you know what, I might as well go ahead and do it now. We talked a little bit, because I'm going to set you up, Doc. I think you're going to enjoy this. Types of organizations that serve youth beyond the American family. And there's a whole discussion there about some of the challenges that are impacting the American family. We got daycares, in home, out of home. We have various types of schools, homes, private, public. We have camps. We heard earlier about foster homes, which I'm a big believer in foster parents, especially to help our social services folks. We have youth ministries, church ministries. We have mentoring organizations, leadership development organizations. We have sports organizations, both from Little League to high school sports, cheerleading, STEM, robotics, exchange programs, both national and international. We have hobby groups, military, Civil Air Patrol, and various programs. We have career development programs. We have after-school and out-of-school programs. We have programs for at-risk youth. We have colleges, universities that administer programs for youth. We have parks and recreation programs. There are inpatient and client institutions that have programs for youth. We have youth in shelters. Do we even use the term orphanages anymore? What is the term now for? Come on, Doc.
I don't know. I don't know what the name of
But you know what I'm talking about, all right? And then we have various programs for youth that are especially challenges. We're at the very core of America in our ability to help in this whole fight. And all of us, I can tell you, all of us across the board, and I have a lot of colleagues with various youth service organizations, want to be a part of the solution to the challenges that are impacting children. And with that, I'll stop. Oh, I'm sorry, Doc.
We have to share a mic. Good afternoon. My name's Nucci-Sack, and I'm actually really honored to say that I am the medical director of the Mount Sinai Adolescent Health Center. We've been talking about the center throughout the past 2 days of this conference, and so I'm going to go into a little more detail about what we do and how our young people come to us. As you know, just as recap, we were established in 1968, and it's really a unique center. And it's unique in the fact that all of the services that are provided there are really specialized to meet the specific healthcare needs of adolescents and young adults. You know that our services are based on medical, sexual and reproductive health, behavioral and mental health, and we also have dental and optical services. In addition, we, as you may have heard from the previous panel, Dr. Stever was here, we have special programming for some of our youth who have more particular special needs. So we have programming that really is integrated into the general adolescent care, but the programming is specific for young people who are HIV positive, transgender youth, teen parenting. We also have a very strong health education platform. We have health educators that work in the center itself with our young people who come in. And then we also have peer educators who we actually recruit. These are the young people who use our services. We bring them in, we train them over the summer, and then we hire them the following fall to go out into the community to engage and to really help young people who they're meeting in the community at community-based organizations, after-school programs, even in schoolyards, to get the word out about responsible sexual decision-making, STI and pregnancy prevention, HIV prevention. What is interesting is that of the over 10,000 young people who walk through our doors on an annual basis, about 90% of them will first come through our doors through the portal of primary care. And I think that this is a really different perspective because the young person necessarily isn't coming in and saying, I need to see a therapist or I need to talk to somebody, even though there are some young people who do that. But the way we do it is if a young person comes in, they have a need, they identify it. Clearly, what we have done is we've created a system where all of our services are confidential, accessible, there's no exchange of money, and they're really welcoming, warm, and engaging. And I think that that's really important for young people. They come in primarily, and we track these stats as part of our monthly data dashboard, but usually they come in through by word of mouth. by family members. So you helped my mother, you helped my cousin, you helped my friend, and then schools, very important in terms of most of the referrals. We're getting an increased number of young people who are finding out about us on the internet. But for the most part, word of mouth is probably the most enduring referral mechanism, because as you know, with young people, adolescents and young adults, the endorsement of a friend or a peer is far more powerful than some endorsement you get off of going onto the internet and just doing a Google search. Each visit is really pretty comprehensive. Now, clearly, we're going to address what the young person comes in for. So whether they come in for an asthma pump, they come in for a pregnancy test, they want to be tested for sexually transmitted infections, they need an immunization, they need a physical for school. Whatever they come in with, of course, we're going to address that, but it's all in context of a greater picture. Each young person gets a rather extensive medical and psychosocial assessment with every visit. So yeah, we're going to address the reason you came in, but we're also going to address a bigger piece of you, because as the young people say, you know, I tell them, well, I need to know about you. How am I going to figure out what's the best plan for you if I don't know about you and your life? What happens is when they come into the room, we engage. And I think the engagement is probably the piece that goes so far. They look for trust. They look for somebody who is going to be helpful to them and not be judgmental, and to reassure them that we can help them with whatever is going on. So I think gaining that trust is really essential. And of course, starting out with the more neutral questions about who do you live with and where do you go to school. But then ultimately we get into the very personal questions. Tell me about your, you know, are you interested? Are you having sex? Do you know? Are you interested in males, females? How do you identify as gender? So we start bringing these questions up, and we do it in such a way that it's very neutral, very natural, and very normative. So when a young person comes in, again, in the context of trauma, we know that trauma is often leads our young people to be very distrustful. So often just setting this very neutral stage and recognizing that we're open to hear you talk about this stuff. If we don't ask about it, I suspect you're not going to tell me about it. But if we ask about it, I'm hoping you'll tell me about it. Maybe if not this visit, another visit when you feel a little more trusting and close and secure. So we do a complete assessment. They get the physical exams that are needed. We are very bullish on prevention. We do STI prevention, pregnancy prevention, big on immunizations. We probably have some of the highest HPV vaccine completion rates in the country. Every visit is an opportunity to address this with the young people. We've created workflows so this all gets checked at every visit. And then, of course, the psychosocial piece. And we have learned that we can sit and we can identify areas that the young person feels that they need to have some help, areas that through our interview we feel that they need to have some help, and then with the young person we create a team around them. Now, I'm also very fortunate to be working in a place where I have these amazing resources with a very talented staff. And I think the unifying force of that staff is that they are all truly adolescent and young adult focused. They are there because they really genuinely, we love the kids. And I think the kids get that, they feel that, and that once they feel secure, they allow themselves to access services as they can tolerate. Clearly, This is something that I think is a model for, I think all medicine should be done like this, to tell you the truth, not just for adolescents and young adults. But adolescents are so uniquely poised. They're at such a very delicate stage of their lives that really having this type of relationship, and I think just the consistency and being an anchor. We've been in the community for 50 years. We've had generations of young people come through our center. And so it's the reliability, and many of our young people that we see, their lives are chaotic, they're disorganized, they don't have anything reliable in their life. They know they can come to the Adolescent Health Center. They can come in. They will get a warm welcome from our registrars. Even our security guards are warm and welcoming and know the young people by their first names. So it's really something that it's a culture that we create. And of course, when things are identified, whether it's sexual abuse, physical abuse, any type of trauma, we have the resources. We have child and adolescent psychiatrists, we have child psychologists, we have social workers, and we have the ability to work with these people in an integrated manner. It's not just, here's an appointment, go see the social worker in 2 weeks. That social worker will meet that young person on the day I'm seeing them if there's a problem that's been identified, because there's just a sweet spot. There's a window of opportunity that if there's a crisis or something that's really bothering the young person that's been disclosed, we want to address it right away, because things, if you've been traumatized over time, get minimized. And so if you don't address it right away, it fades away and the cycle continues. So that's kind of a broad overview of what I do and how we do it.
So let me just say, Anne made reference to the amazing resources, and I think I can probably speak for all of the panelists when I say that no matter how well you feel resourced, nobody should ever feel discouraged from writing out a check and contributing to enhance the level of resources at any of these agencies. But let me ask you, Anne, so this screening process that you've described, is there a particular aspect of the screening process that's designed to try and identify whether or not a child has been the victim of violence, sexual or otherwise, and whether there is or there isn't, what kinds of resistance do you meet from kids who have been victimized in your attempts to help them, to both treat them and to address whatever the nature of that violence might be?
Okay, the screening process. We use a pretty standard, it's a validated instrument called the HEADS assessment, and anybody who's in adolescent medicine or in pediatrics knows this. It's a validated instrument that was really created for adolescents as a depression screen, because often when young people are depressed, if they don't ordinarily have the signs of feeling hopeless and helpless and like sleeping all the time or eating. If they do, yes, I get it, you're depressed. But a lot of adolescents will have what are called depressive equivalents. So they start having like these risk-taking behaviors in other domains of their life. So they actually looked at this, and HEADS is an acronym for home, education, activity, diet, drugs, sex, suicide, and strengths. What we do is if you start asking somebody about who do you live with, where do you go to school, are you in school, how you doing, what you start is a very neutral type of questioning, and this is where the rapport starts to build. And then as you get into more sensitive, what do you do on the weekends, what do you do in your free time if you're not studying, when you go out with your friends, anybody smoking? Do you smoke? Do you smoke cigarettes? Do you smoke hookah? Hookah's very popular these days, oh, by the by. It's never included in the tobacco run, but it's very popular. Probably more popular than cigarettes at this point in New York City. And then, of course, weed, marijuana, alcohol, all other substances of abuse. And then we started to get into sexuality, volitional sexuality, types of sexual activity. So we're very direct. I know from panels this morning, people were trying to say, you really need to be direct. We're very frank and direct, but it's in the context of this very trusting engagement that there's a real alliance that's created that I think it allows the young person to feel safe in disclosing many things that they perhaps have never been asked, or they would be a little hesitant to respond to because they didn't feel that this was something that was important and that they could trust the person they were telling. And then we get into, has anybody ever touched you in a way that you didn't want them to touch you? So then, and we get into very clear about, has anybody touched your breasts? Have they touched your vagina? Have they touched your buttocks? Has anybody raped you, coerced you? And I mean, I have to say, well, the good news is I've been doing it for a long time. I guess that's not bad news. The long time is the bad news, I guess. But I've had people who have disclosed first time forever sexual assault or sexual abuse sitting with me in a room, and they're 15 or 16 years old when something had been going on starting at age 8 and then went to age 12 or went to age 13. The perpetrator, again, usually being somebody in the home, where there is also some question about why would you say this about this person in the home, and the young person not being believed, and the whole distrust that goes there. It's really a pretty salient moment in an exam room. So then the next question is how do I get that young person to the social worker? I can't just say, hold that thought, I'm gonna go get somebody who can actually, really work with you. So what we do is we've created actually what we call primary care social work. So we actually have this, social workers can actually come into the room with us when we're doing medical interviews, and so they can listen to the young person too. So the young person understands that they're connecting with me as the medical provider, and that with this person sitting next to me, we're a team. And so anything you tell me, it's really good because we're both here now on your side to help you. And then when it comes for the physical, the social worker gets up and goes away. And then at the end, it's like, are we going to reconnect with Sarah or Rachel, whoever the social worker is? And then they just come and get the young person and they go off, and a connection is made. Some young people are more resistant. And so with those young people, what we tend to do, and they're resistant, I ask them, I've probed their resistance. Why don't you want to see a social worker? You tell me, every time you come, you tell me your life is chaotic, you're living in a really bad situation, but when I say, let me get you to somebody who can help, you say, oh, I gotta go. Oh, I gotta get to work. I said, but you just told me you don't work. So, they make up excuses. And I think young people who have been in the system, who have been traumatized enough, and they know that if you say the word social worker, they feel like child protection services, and that there's going to be more discord in their life, and they're going to be picked up from one place and mandated to another. So they kind of slide around it, and only after a while, when you can get that young person to keep coming back for their medical care, that you can actually, through motivational interviewing, and of course, all of our care is trauma-informed, that we can actually create a therapeutic alliance with these young people who can then trust us to say, no, you really need to trust my judgment here, and just sit with the person once. You don't have to see them forever. And once they do connect, though, the connection is really pretty profound. And in fact, they stay on for a long time, and it's a very successful model of moving the young people to and from and getting them to connect to the services that they need, because there's such an underlying distrust that I think we work around and just keep creating this sense of you're safe, you're safe, you're safe.
I wonder, Michael, I wanted to ask you, what are the primary policies and procedures of the Boy Scouts with regards to violence against children? But I wonder if you can answer that question also with a special eye on what Ann was just talking about with regards to trust, and the struggle with the level of trust necessary to both be able to identify the problem and to address the problem.
Thank you very much. One of my responsibilities, my primary responsibilities with Boy Scouts is development of policies, procedures, and trainings for both our youth, our parents, our volunteer leaders, as well as our staff. And we use a quasi-medical model. I think it's a good way for us to look at it, which is primary, secondary, tertiary, and simplifying that, make it around prevention, recognition, and how we respond or how we report. In the area of prevention, it's for us, and I think everybody needs to understand, I'm a retired police detective that investigated child abuse, specifically child sexual abuse. It did my heart good to see the Children's Advocacy Center folks and the prosecutors and the forensic interviewers up here earlier this morning. I did interviews of children about child sexual abuse before there was anything called forensic interviewers. And then into that model and help with creation of multidisciplinary teams and children's advocacy centers from around the country. So I have two lenses, if you will. I've got the youth servant organization lens, plus that lens also. So I wanted to say that to put in context this issue surrounding offenses against children. For simplistically, it's about perpetrators having access and opportunity. There's a lot more to it, but it's about reduction of access and opportunity. And I want to qualify this by saying this. What I'm talking about suits the Boy Scouts of America's Youth Servant Organization program. Any policies that I talk about need to be looked at, if you will, and applied to the mission and how another youth servant organization works, because it may not fit their program. Okay, so I think that's very important to say. You're more than welcome to go to Google Boy Scouts of America Youth Protection Policies and look at them all and begin there. A lot of youth servant organizations that start out or on a regular basis do that. Probably our biggest ones that we're noted for are the Too Deep Leadership Policy. At least 2 registered adults must be present anytime there's any type of program activity. Adults are never supposed to be one-on-one with youth, period. We applied that into digital communications, texting, phone, online games. We just don't allow it. We don't have it. Now, if somebody violates a policy, does it mean they're trying to groom a child? Because to me, policies and prevention policies are really, if you're in the field, are sort of our concern about minimizing that access and opportunity and reducing opportunities for grooming, if you will, all right, which is a big issue in the area of child sexual abuse. So if a person violates the policies, does it mean he's trying to groom a child? No, but we know for a fact that that's what perpetrators are going to do. They're going to seek opportunities to isolate that child. So we have those policies in place. It's part of our culture. If anybody's here involved in scouting, if I mention the term youth protection, people know exactly what it is we're talking about. It's mandatory training, it's our policies, it's our procedures, it's how we live in our organization to keep kids safe. A new policy, I'll be more than willing to share with you based on my experience investigating child sexual abuse, specifically youth on youth. I got to give homage to the University of Oklahoma Health Science Center, Dr. Barbara Bonner. I got to plug her and her team. And the deceased, Dr. Mark Chafin. He's the one that I really worked with a lot. But if you know anything about youth on youth sexual abuse, violence, or what have you, you know that youth perpetrators, tend to be 4 to 5 years older than their victims. That victimization actually usually starts in the home, but it also can apply outside the program. There's a lot more to that, but the point I want to get to is we now have a policy that does not allow for youth more than 2 years of age difference to be in any situation where there may not be an adult present, typically tenting, and other areas or what have you, because 16, 17-year-olds will tend to bully and harass the younger kids. And heaven forbid, I see some people nodding their heads, and you know what I'm talking about. All right, so that goes beyond. So if you want to talk about those dynamics a little bit more, get with me, but it's consistent with what review of incidences, as well as what the research says. Some of the folks have done a lot of work in that area, the American Camp Association, and so they are really excited about the opportunity to look at that policy. Another policy I think is very important. Probably 5 or 6 years ago, I sat down and read literally every child abuse reporting policy legislation in every state. I literally did that. It was a long weekend. And I cannot stress to you the inconsistencies in mandatory report of child abuse legislation, if anybody's done that. Boy Scouts of America has effectively made everybody in our organization mandated reporters of abuse. Plain and simple. We did it as a national policy. I'll tell you a quick story. And I'm not one, and you'll never hear me throw another youth servant organization under the bus, but I think everybody here knows about Penn State, specifically Jerry Sandusky. By law, the University of Pennsylvania was not required to report child sexual abuse. A lot of people don't know that, but they weren't. And so whenever you have a prevention training that says to their people, look at your state law to find out if you're a mandated reporter of abuse, well, that's fundamentally wrong or problematic, because somebody may literally do that and they may not be legislatively responsible to report, because a mandated reporter is usually something that is specifically identified in the law, and usually there's training and what have you. We're a national organization. We're in every state, in many countries, and most military bases, or we have our armed forces in service. And so we effectively created a policy called a mandated reporter of child abuse policy. I got to give a plug to the National District Attorneys Association and Victor Veith, JD, for assisting us with creation of that policy. Now, moving real quickly, and I have a bunch of stuff I can share, but I'm going to hit a couple of other ones I think are very important. We have a 24/7 Scouts First, we call it helpline. It is not an abdication to anybody in Scouting's reporting responsibilities to law enforcement, child protective services, or even to the cyber tip line of the National Center for Missing and Exploited Children. However, there's another little weakness in a lot of training around prevention training, and that is the assumption that if a parent or a leader or a volunteer or a staff person suspects abuse, most training says report it to law enforcement, child protective services. Well, that's not how reality works. Most people, if they suspect something, they want to what? They want to talk to somebody about it. They want to talk to an expert about it. They may call one of you since they know that you work in this area, or they may call the Youth Protection Department. So we give people the opportunity, if they're not quite sure if that individual that's engaging that young man via text at 1:30 in the morning, or that young lady or whatever, they're not quite sure, we have experts back at the National Office of Boy Scouts that will man the phone, that are manning the phone to have that conversation. One of the biggest areas, I think it's great. I'll just go ahead and say that. I know it's a little bit of a slip, but I think it's great. Things that we have recently engaged in the last 4 or 5 years in a very direct way is engaging survivors, specifically male survivors. I don't remember the lady's name that was on a previous panel that represented New York and outreach in the LGBTQ community. But it's amazed me, being in the field for 35, pushing 40 years now, that community, as well as the male survivor community, are literally having to sit down with clinicians and educate them on how to talk to their communities. You would think they're getting that training in college, in universities, and whatever, but the fact of the matter is that they're not. And so one of the things we've learned a lot, and I know a couple of people that have been around a while, is, and everybody, just want to acknowledge that Joy Frost, former director of the Office of Victims of Crime, if you guys happen to know of her, you definitely know of her work. She passed away about a week ago, complications of cancer, so I just wanted to acknowledge her. But she and her staff have assisted us in not only that formal outreach to survivor communities, in engaging them and actually having them come and present at our conferences and speaking to our professionals and staff, as well as part of our new youth protection training. But they also encourage us to ensure that we have a unquestioned opportunity for any victims and survivors of abuse to get counseling. And so any victim, past, present, whatever the issue is, sexual abuse, bullying, harassment, that needs counseling, we will provide that for them. So those are some of the areas. And in doing that, we have that opportunity to get that information so that we can do the right thing, whether it's report to CPS, law enforcement, or give appropriate support that's needed.
I've gotten a 10-minute signal, and I do want to have an opportunity for people to ask questions. I have a couple of questions for Chandra, and I'm just going to apologize publicly to Carlos if I don't have a chance to direct a couple of the other thoughts that I had for him as well. But Chandra, we spoke in preparation for this a little bit, and there were a couple of things that you said during the course of our conversation that struck me as compelling. You talked about that we need to understand violence against children as a continuum, and you also talked about, and I don't know if you think that there's a link, but you talked about the failure at times to see violence in communities because of the way that it's been normalized. Can you elaborate on that a bit?
Sure, and I think they are linked, in fact. I'll speak about them both, and hopefully shortly, so Carlos gets a chance as well. So I think that one of the things that we are seeing both at community level and through research in South Africa is that children who experience emotional abuse, conflict at home, experience their parents fighting physically, are more at risk of being involved in fights at school, of being bullied or being bullies at school themselves. And we know as well that they're at increased risk of then going on to either perpetrate or become victims of violence in their communities as well. So I think that one of the things that is very clear to us, and we see it in small practical ways amongst children at community level, is just that where conflict, aggression, violence are normal, you're going to find it repeated throughout a child's life. And so to try and separate out gender-based violence, intimate partner violence, bullying, and say these things are unconnected, they're different types of violence. It's true that there are different types of violence, and it's true that different strategies work for different forms of violence. But essentially, we need to really be looking at what's happening to children from the very early age. I think this morning people were speaking about the importance of 0 to 10. And I think that's absolutely right. I think 0 to 10 is a critical time, which is not to say that beyond 10 we ignore children. Of course, there's interventions beyond that as well. But I think it's also important to understand that even, and the research is beginning to show this increasingly, even community-level violence, in South Africa we have a lot of protest violence. Community-level violence can be linked back as well to experience of violence earlier in life. So it's about normalizing aggression, conflict as a way of solving problems, really. And this is what we need to address if we want to look, really get to the big macro picture of lowering levels of violence across society. So what is related to that in the community in which I work, because we don't have the kind of resources. I wanted just to invite Mount Sinai to South Africa. I mean, really, it was just wonderful to hear what you do. It would just be wonderful to have those kind of resources at hand for our kids. But I think what we find is that very often, because we are many NGOs in South Africa, community-based organizations, we employ local staff because that's the people we can afford. They're very often not very well skilled. They don't have a lot of experience in working with children. They certainly aren't ideal childcare workers. And they come from experience of homes that are themselves full of conflict and places where violence is normalized. And so in the early years of our organization, we would find our homework class facilitators not even seeing when bullying was taking place because they wouldn't recognize it as bullying. It's very funny at the moment because we've got an increased quality of staff and staff who've been with us for a long time. They're beginning to feel as though violence has gotten a lot worse in our community because they're seeing it for the first time. Before, they wouldn't have recognized acts of aggression as acts of violence. And now that they're feeling quite overwhelmed by it. In fact, it's really interesting.
And the point of normalization is exactly at where we are at the crossroads for Big Brothers Big Sisters, many of our urban centers, more at-risk communities where simply walking to school can be a traumatic experience. Right. Where you experience or witness violence, direct violence. And we have this initiative in my agency where it's called the Occupy the Schools, where we have a lot of our mentors come in and kick off the day and offer positive energy once a week as kids are walking to school. But often is the case that we're confronted with a response that our kids are already, their hearts are heavy, their heads are low because they've already witnessed something that's disproportionately tragic to what they should be experiencing as young people trying to just get to their education. And so in those spaces, we're trying to be cheering and literally high-fiving a lot of positive energy to kick off the day, and we typically kick off the day with a speech or a presentation of some sort, but often have to reroute to meet the children where they are. And then we see the manifestations we hear at the end of the day sometimes. The fights beget more fights, and then the end of the day becomes a chaos. So the point of chaos is spot on, especially where we are. But I think the pivot point for me, as we're talking about this panel discussion, service in action, we can be that action. We can be that point of prevention, that point of positivity, that light in these children, in our young people's lives. And it could be, more expert like Mount Sinai would provide, or it could be just simply being present in a child's life, like a positive adult mentor could be. And I often liken being a big brother or big sister as a lighthouse. When it's a beautiful sunny day, you might not recognize the lighthouse, you might not see it, but when the storm comes to you, as it often does for many of our kids, it may feel dark, and it may be necessary for you to avoid crashing into the coast. And so your presence, the presence of a positive, regular, loving adult, and the power of unconditional love is what we all as human beings need. Yet, like Michael was talking about, many of our kids often don't have this, and it's beyond their control in which they're born into certain demographics that are not of their making. But we can be part of rerouting some of this and being part of a solution, especially in our own communities. We can manifest that anywhere in the world if we want.
We have 2 minutes, so I'll just do this by way of a closing comment. But there's something that you just said, Carlos, that just sort of resonates with me so much, which is that we spend so much of our time, as helping professionals, responding to crises in communities and crises in individual lives. And one of the challenges, or one of the things about prevention, is that if you do something that ended up having a preventive impact so that violence doesn't occur, you don't know it, right?
True statement.
It didn't occur. You don't know it.
Yes. Yes.
Which makes it very hard to measure,
How to scale it, right?
the quality and the impact of whatever your contribution has been. And we're so much, it's a stupid analogy. People go to the gym and, people don't do sit-ups because when you're done doing your sit-ups, you don't look at your stomach and say, wow, my stomach looks great. You do curls or something like that because you look in the mirror, you think, boy, my bicep seems bloated and inflated. We want that, we want to see the impact. We want to see the result of what we've done. And obviously there are so many people that are in need, that there is a critical need for people to serve that population. But I think that, part of what everybody has talked about, and Carlos's last words go to, is that, but if we can prevent it, you'll never know. All of us carries around with us something that was said to us by somebody in our lives. And you never told that person that, boy, that thing that you said to me 15 years ago has just been with me forever. You've never told that person. We all know that people have had that kind of impact on our lives. And part of what we're talking about here is finding ways to have that impact without necessarily knowing ever that you have. But only the test of time will demonstrate that. And it's an act of faith. And I'm so privileged and honored to be working with 4 people on this panel that engage in that kind of act of faith every single day. And I thank them very much for today and for your contributions in general. Thank you.